Welcome to Sociology 102, Police Violence, Black Lives Matter, and the COVID-19 Pandemic. I'm your instructor, Professor Wherry, and I'm really pleased to be joined today by Dr. Tyson, who is an associate professor, Tyson Brown, associate professor at Duke University and the Department of Sociology, and the director of the Center on Health and Society. So we've been talking about COVID-19, the disparate impacts of the COVID-19 pandemic by race. And at this point, about 1 out of 1,000 Black folks have died in the coronavirus, more than twice the white rate. We're also seeing high rates for Indigenous populations, for Pacific Islanders, for Latinx folks. But these rates are, still lower than the Black rate. So what's going on and what should we think about these numbers?
Yeah, well, Fred, thank you so much for having me. I appreciate the opportunity to come and talk with you about this really important topic that's affecting so many people. And what you said is exactly right. The United States has become the epicenter of the coronavirus pandemic. We have some of the highest rates of cases and COVID mortality. And this is especially high in the Black community. And, this makes me think of that phrase that many of us have heard that, when America gets the cold, Black America gets the flu, right? To really highlight how these things often have a disparate impact within communities of color and in the Black community in particular. And, I just want to take a moment to reflect on this and discuss, what may be driving some of these inequalities. And there's been a number of misconceptions that I've seen and heard in the media, as well as from lay folks, about the causes of these racial inequalities in health disparities in general, and in COVID in particular. And one of the most common things that folks often think about unfoundedly is this notion that there may be genetic underpinnings to these disparities. And the science simply doesn't support this view. We know that there is 8.6 times more genetic variation within racial groups, so-called racial groups, than there is between racial groups. And there's no evidence to suggest that genetics is a basis for health disparities writ large or for the COVID pandemic. Another common explanation that folks think about oftentimes is the role of culture and health behaviors. And, we heard a lot about this even from senior administration officials early on in the pandemic, directly from the Surgeon General, in fact, where unfortunately he seemed to almost blame the victims, discussing things about, certain health behaviors that may lead to worse health outcomes in communities of color. And that really isn't borne out by the evidence either. So there's this notion, and that's largely because in the Black community, the rates of smoking and alcohol abuse and drug abuse are comparable or even better than that in the white community. And so there's really no support for the idea that these inequalities are being driven by genetics or culture or behavior. However, there is growing evidence that structural racism may play a key role. And so in several recent studies, my colleagues and I show that structural racism is a fundamental cause of racial disparities in the COVID pandemic and health in general.
Well, so when we're talking about racism in society, and you write about structural racism in health, help us understand what you mean when you say structural racism and how it works with health outcomes.
Yeah, exactly. So when people think of racism, they often envision this overt act or statement of interpersonal discrimination. Mm-hmm. But much of discrimination occurs at the societal or the macro level, and it's not perceived. So I think it's really important to investigate the impact of diffuse and covert forms of racism that are oftentimes embedded in institutions and structures of society. Despite the centrality of structural racism in the social science literature as an explanation for racialized life chances, there's often been a lack of clarity on exactly what structural racism is and how to measure it. And this is surprising because, as we know, more than a century ago, W.E.B. Du Bois was discussing and conceptualizing and measuring structural racism, literally over 100 years ago, which is, in some ways we've made progress, but in some ways there's still a lot to be done in sort of providing greater analytical and methodological clarity. So I'm actually working on a project with Patricia Homan at Florida State University, where we distill 5 key tenets of theories of structural racism after doing a broad sort of overview and literature search. And what we find are these 5 key tenets really stand out that are often present in descriptions and analyses of structural racism. And the first is that structural racism is really multifaceted. And by that I mean that it's broad-based across societal institutions and domains, including things like educational and criminal justice systems, which we hear a lot about in the news. That's not a surprise. But also the labor market, as well as housing and politics. And another key feature that I think it's important to highlight is that these different domains and institutions are interconnected, right? And so oftentimes you can't just isolate one. We know, for example, that where one lives has a great impact on their life chances in terms of their education, their job opportunities, their social networks, their health, their well-being, their political representation. So these things are really interconnected. And ultimately, third, it involves this institutionalized system, right? These things combine in a system. You know, I think about the work of systems theorists as well as folks like Barbara Ruskin that talk about this discrimination system where the whole is really greater than the sum of their parts. And then a fourth key tenet is that it involves this relational subordination and superordination, right? And then fifth, that ultimately structural racism manifests in racial inequalities. The idea is that the racial inequalities that we observe in society are oftentimes driven by structural racism. And so we draw on these 5 tenets to try to advance the field by positing that structural racism involves a multifaceted, interconnected, and institutionalized system of relational subordination for people of color and superordination for whites, and that this is observable as manifest, concrete racial inequalities in life chances. And so with respect to the COVID pandemic, I'll just say that the idea is that structural racism leads to racial disparities via a handful of mechanisms. And I'd like to just talk about 3 of them that were highlighted in a recent article published in the Journal of Gerontology, along with Mark Garcia, Catherine Garcia, and Patricia Homan. And the first is that structural racism leads to unequal exposure to infectious diseases, including COVID. And this is due in part to dramatic racial segregation in where people live. We know that Blacks and whites live in very different types of neighborhoods. So it's not just the racial composition of the neighborhood. In fact, that's not really the key feature. It's that there's both this social isolation and marginalization and really deep and broad economic inequality within these Black communities oftentimes. And as a result of this residential segregation and housing, there's also segregation in schools and jobs. And so what you have is this toxic cocktail of structural disadvantage where folks are living in communities where it's unsafe. You may not have access to good health care. Oftentimes there's overcrowding in housing. There may be a lack of safe, effective transportation. So folks may be relying on public transportation. And so then that increases one's exposure. Oftentimes also, as a result of discrimination in the labor market, Black folks are less likely than whites to have white-collar jobs where they can isolate at home and do work remotely. And so they're oftentimes on the front lines as so-called essential workers, whether it's working in retail or service positions, or even if it's driving Uber or Lyft, something along those lines, where folks are really on the front lines and being exposed to other individuals. And then of course they're going back home, maybe they're taking public transportation home, then they're in more crowded housing. So there's less opportunities to physically distance, right? And on top of that, there's fewer resources, right, to be able to weather this thing. And so, there's oftentimes financial imperative to continue working. Many folks don't have the luxury of staying home and saying, well, I'm just gonna not work this month, or I'm gonna quit my job, because there's this massive wealth gap, which I know you know and discuss in your work. And so Black households are less likely than white households to have that nest egg of savings to be able to weather the financial shocks of something like this recession that we're experiencing. And as a result, they're much more exposed to the virus. They're less able to stay at home. We can also think about exposure within prisons, right? We know that Black people are much, greatly overrepresented in the carceral system at all levels, and that, these are really hotbeds for outbreaks. And so there's few opportunities to physically distance. And then the second way that my colleagues and I discuss how structural racism impacts COVID is through sort of what we refer to as weathering processes. And what this refers to is the fact that as a result of cumulative adversity, Black Americans have earlier and more rapid health declines than white adults. And so they sort of physiologically, they are sicker and older in a lot of ways. And as a result, makes them much more vulnerable to harmful outcomes stemming from COVID infections. And so this is really a key driver. You've been hearing a little bit about this in the news, actually a little bit more than a little bit, right? So we've been talking a lot about high rates of diabetes and hypertension and health or heart disease. But I think it's useful to step back and say, well, what's the cause of those disparities, right? And so what's the cause of these causes, sort of? And we argue that structural racism is the fundamental cause of these so-called more proximate causes, and that really structural racism is the pathological pre-existing condition that leads to these other potential mechanisms. And then the third way that we argue that structural racism impacts unequal outcomes with respect to COVID is with respect to unequal access and quality of healthcare, right? And so this is well documented. We know that whites receive better healthcare. They have more access to healthcare. There's testing sites. There's data that shows that testing sites are disproportionately located in white and wealthy neighborhoods. And then when folks actually, when Black people actually seek care, they have less access. They receive diminished quality. They're less likely to be believed. Where they go, for these services, they're less likely to have appropriate tests, and that they're not often located in their communities, and that can be a problem when some folks don't have reliable transportation. So these are some of the ways that I've been thinking about this, along with some of my colleagues.
Yeah, it's funny that it reminds me, growing up in South Carolina, I would hear, as we called them, the old folks, and they would say, I'm sick and tired of being sick and tired. Mm-hmm. But in this case, they're sick and tired as a result of the cumulative effects of being sick and tired through this weathering process and unequal exposure and the lack of access to quality healthcare. So this is once you say it, it makes sense. The lines get connected to the dots. But I think particularly as we have conversations about racism and how it works, it's hard for a lot of people to connect the dots. And so as you have connected these dots, you and your colleagues, it would be helpful, I think, to kind of go behind the scenes. So here you are, you're trying to say that there's this thing, structural racism. It's a sickness. And so just like we give someone sick a thermometer and take a number of other types of tests, how did you sort of behind the scenes, how did you think about producing this measure in order to sort of see and measure structural racism?
Well, that's a great question. And there's a lot in there. I'll try to unpack this. But, essentially, as I mentioned before, there's been this disconnect between theory and measurement. And so one of the things that we're trying to do is we're trying to connect our measurement of structural racism to some of the tenets that I mentioned before. And those are that it's multifaceted, interconnected, involves a system. It's a system involving institutions as well as relational subordination, and that you can observe this in terms of racial inequalities. And we're doing this by looking at sort of exploiting state level variation in Black-white inequalities in an array of domains, including in education, as well as in unemployment and earnings and home ownership, as well as with respect to disenfranchisement rates at the state level and political representation as well. And then also looking at things like black-white inequalities in incarceration, and as well as looking at segregation, which is sort of received a great deal of attention in the literature as being a primary driver of structural racism. But I think that one of the unique things that we're trying to do here is not only cast a wide net and look at it across an array of domains, but then think carefully about what theory would suggest how these things interrelate. And I think it's really important to not try to look at these things in isolation, because the theory really suggests that they work in concert. And so I think it's really useful to think of it as a system and come up with more of a comprehensive approach. And so looking at how they combine, so black-white inequalities in education, in the labor market, in housing, in politics, and in the criminal justice system, how they combine to shape health outcomes. And what we do when we put these things together, we find that they sort of hang together quite well. We use this measure called Cronbach's alpha, and it suggests that there's this high level of internal consistency between these measures. And so it suggests that but they hang together quite well. So we can think of them as perhaps a unit in a sense. And that what we find when we exploit state level differences in structural racism, some states have, I just want to say all states are high, right? So in all these domains, there is structural racism in every single state. But we just find that there is some variability across states, and some states are a little bit higher, sometimes a lot higher in some of the domains. And that when you cast a wide net, you can kind of get a sense for the overall sort of structural racism of a state, while admitting that there's clearly heterogeneity within these states. But we find really overwhelmingly consistent and I think compelling results that shows that higher levels of structural racism are linked to worse health outcomes for Blacks. And we look at this across 6 different health outcomes. We use 2 different data sets, the Health and Retirement Study, as well as the BRFSS study, which is studied by the CDC. And we see that Blacks have worse health with respect to functional limitations, with respect to self-rated health, BMI, depressive symptoms, as well as other mental health days, for every single one of these outcomes. And for none of these outcomes is structural racism related to the health of whites in a negative manner. But we did find some evidence in the BRFSS that whites do perhaps benefit from higher levels of structural racism with respect to their mental health. And so this is an early study. We're building on a handful of previous studies, but in some ways it's a departure in that we're really trying to cast a wide net and take a comprehensive approach, both in measuring structural racism as well as measuring its impact on a wide array of health outcomes.
Oh, yeah. It also suggests that as we get structural racism right, there are other types of structural disadvantages that we might also do better at, right, in terms of measurement. This is what it means to sort of do cumulative, sort of long-term work. That's not easy because I sometimes find, particularly in conversations with my students, with other professors and people outside of the academy, whenever racism comes up, everyone just gets nervous, and it just feels like it can be whatever you want it to be. And it's good to see you and your team kind of nailing some of this down. And so as I think about what you're doing more broadly to nail this and many other things down with respect to society and health, but I'd like to close this out by just hearing a little bit about what you've been doing as the director of the Center for Health and Society there at Duke University, because I'm sure that your center is up to quite a lot these days.
Oh, well, thank you for that opportunity. Yeah, well, and I want to discuss that. And before mentioning that, I also just want to mention that we also need data on how other systems of oppression, such as structural sexism and economic inequality and LGBT discrimination, to really understand how these things combine to shape population health. 'Cause I see that as sort of a frontier, sort of the next steps. And I'm working as a co-author along with Patricia Homan on a project that looks at that. But yes, Yes, there are definitely exciting things going on here at Duke with respect to this research. I have the opportunity to help lead a center on health and society. And I think that one of the main features of our work there has been working on this study over the last 3 or 4 years. It's called the SOLSAA study, and that stands for the study of longevity, study of longevity and stress among African Americans. And what this is where we're looking at how biopsychosocial processes shape the health among older Black families. And so it's this really interesting design where we're able to look at variation within families and look at different family types. Some families where there's a long-lived adult member, so folks who are, say, 75 and older, so 75 and maybe 102, I think is our oldest participant. As well as looking at the children. And so the children, meaning, they're oftentimes above the age of 50, so they're 50 to 75, and siblings. So you've got this really interesting sort of horizontal and vertical family design where you can look at how differences across these families in terms of exposure to economic adversity and stressors lead to these biological processes such as inflammation and physiological dysregulation, how those lead to worse health outcomes along the road. And I'm working on a team with this, so I am sort of the lead at Duke, and then the PIs for the parent grant. Keith Whitfield is the new president of UNLV, and Roland Thorpe, who is a professor of public health and the new president of the Interdisciplinary Association for Population Health Science. So we're working on this together, and it's been quite a learning experience. It's an ambitious study funded by the NIH where we're going out and we are interviewing 750 older African Americans within North Carolina, and we're doing a deep dive and sort of getting an assessment of their family dynamics and looking at, as I mentioned, the parents, the siblings, the children, and casting a wide net and looking, across economics and psychosocial factors and looking at their history of where they've lived and what they've done and their relationship statuses and their health practices and just a range of outcomes, and also collecting biomarkers to get a handle on how these social inequalities lead to biological processes that ultimately undermine their health. So that's been a really big part of what we're doing at the Center on Health and Society. Some of the other things that I'm excited about are that we've had opportunities to provide training opportunities for graduate students. So this sometimes involves things like going and getting training in certain methods at the ICPSR or other trainings workshops across the country. And then another key feature of the center has been really trying to connect an interdisciplinary team of scholars from across campus that are interested in these issues of health equity. That I think has been really great. And then the final thing that center has been doing over the last few years is we've been able to do this weekly writing group and also several writing retreats throughout the year, where we're bringing Black faculty together to build community and then also enhance our productivity. As we know, our lives get very busy, and so it's nice to have some sort of dedicated, protected time so that we can, do the thing that we love to do, which is our work, which is our science, which is our writing. And so those are the key things that we've been up to at the center lately.
Yes, and we are fortunate to be able to have you here with us today. We're especially fortunate to see the work that you and others are doing out of the Center for Health and Society and in your sort of work program more generally. And I really do believe in this conversation and the many conversations I've had that the social sciences and sociologists in particular are going to really be able to help us as a society not only understand our problems, but intervene in those problems in ways that will make people's lives better. And so thank you with much gratitude for your work and for your commitment to doing, the morally urgent and necessary thing to not just call out racism, but to diagnose it, to measure it, and to find with greater precision how it operates structurally with great effect. So Thank you so much for joining us. And I look forward to when we can see each other again in person after the troubles pass.
Yes, exactly. Thank you so much for having me.
Thank you.